We're very excited to have Dr. Correll here with us to present on cognitive impairment associated with schizophrenia, a focus on pathophysiology, burden of disease, and clinical management, provided by the France Foundation. Dr. Correll is a professor at the Institute of Behavioral Science, Feinstein Institutes for Medical Research, and the medical director of the Recognition and Prevention Program. Also in the Department of Psychiatry of Zucker Hillside Hospital, a professor of psychiatry and molecular medicine at the Donald and Barbara Zucker School of Medicine at Hofstra, Northwell. I think that's it for all your titles, Dr. Correll, but please feel free to do a further introduction if I missed anything. And thanks so much, everyone, for joining.
Great. Thanks very much, Erica. Thank you all for spending time on this grand rounds. And hopefully at the end of this, you will have had some food for thought and also can take something home in terms of how to treat patients with schizophrenia in a better way. So this is about a dimension that is not so much of a focus because at the moment there's little we can do, but there is something we can do, and that's cognition in association with schizophrenia. We'll focus on the pathophysiology, burden of disease, and clinical management. These slides have been put together by Cyril de Souza from Yale University and myself. And I'm both, as you heard, professor of psychiatry and molecular medicine at the Zucker School of Medicine in New York. And I'm also professor and chair, Department of Child and Adolescent Psychiatry at the Charité University in Berlin. So I'll be presenting this, but I will not just do a frontal presentation. We want you to participate. So there will be multiple questions posed that you either think about or can maybe even voice your opinion on. This is my disclosure information and also the disclosure information by Dr. de Souza. And we have generous support from Boehringer Ingelheim, although the slides were totally selected independent of this support by Dr. de Souza and myself. We are advisors to that company, but and we'll talk about one medication in development at the very end, but there is nothing yet marketed by Boehringer Ingelheim in the CNS space, although they're looking at various indications, MDD, PTSD, borderline disorder, negative and cognitive symptoms. Now, we'll talk about how to recognize the burden of cognitive impairment associated with schizophrenia. We call that CIAS, cognitive impairment associated with schizophrenia. How to differentiate cognitive impairment from the more traditionally focused on parts of schizophrenia being positive and negative symptoms. And then also, what about assessments and assessing also the ongoing developments and finally, hopefully, finding something that can help people with schizophrenia and cognitive symptoms. So the first question for you, and you can basically here get your QR code, scan it, and then please answer the questions because we'll also go back to those and then review what your opinion was before the talk and after the talk. And hopefully there was some learning. So please scan the QR code, or you can also actually enter the answer, I think, on screen if you're on the screen. And the first question is, what proportion of patients with schizophrenia actually have cognitive deficits? Cognitive deficits defined as being significantly worse in cognition than the general population. Okay? Is it a quarter, half, 3/4, or everyone? So how many patients, what proportion of people with schizophrenia have cognitive deficits? 25, 50, 75, 100%. Please make your choice now. And generally, usually, I also see the question on my screen, which I don't yet. So people will also not see it and can only answer via the QR code. I don't know whether that's the desired fashion in this grand rounds. All right, after you've answered this, second question. We'll go to Joe. Joe will be with us throughout this discussion and presentation. So I'll introduce him now. Joe is a 23-year-old white male, had his first episode of schizophrenia a year ago. He does not have comorbid substance use disorder. You are going to see him for the first outpatient appointment. He's switching over to you. And based on the epidemiology of the illness, which clinically relevant symptoms is he most likely to have? So he's not an inpatient anymore. He's on antipsychotic treatment. What would you most likely to see? All of them are possible, but what's the biggest likelihood? Positive symptoms, negative symptoms, cognitive symptoms, or depressive symptoms. So which of the 4 symptom clusters here will you most likely encounter? Positive, negative, cognitive, or depressive symptoms, A, B, C, D. And as I said, Joe will be with us during his treatment journey. And then last question, which is a mechanistic one, and we'll turn to that at the end of the talk. Which of the following mechanism of action is currently under development for cognitive dysfunction in schizophrenia in phase 3? So it's very far advanced. Is it GABA agonism, glycine transporter 1 inhibition, M4 muscarinic agonism, serotonin 2A inverse agonism, or TAAR1 agonism, which is trace amine associated receptor 1 agonism. So please make your choice now. I hope at the end of the talk you'll be much more equipped to answer this. GABA, glycine transporter 1, M4 muscarinic, serotonin 2A inverse agonism, or TAAR1 agonism. Please make your choice now. So I hope, since I can't see the questions, that at the end we'll actually see the answers that you have given. If not, then I'll ad-lib what the real answer would have been. All right, good. So let's go to Joe. You've already met him. He's 23-year-old. He's white. Had his first episode a year ago. Back then, he believed that people could read his mind and that college mates were plotting against him. He couldn't study anymore. He was socially withdrawn at first and then actually became agitated, prompting his first hospitalization. There, aripiprazole was tried first, but it only insufficiently resolved his positive symptoms. He was then, during that admission, switched to risperidone, and the positive symptoms largely resolved. The current condition, remember, you see him for the first time in your outpatient encounter. He has little interest in going out, meeting prior friends, spending time with his brother, who he usually spent time with. And he also doesn't read the newspaper or books anymore, which he enjoyed doing before. So, question for you. What signs and symptoms does he actually exhibit? How might the patient talk about it? And what questions might you want to ask to get more information? Anyone? What signs and symptoms? How would he talk about it? What questions might you want to ask? So little interest in going out, meeting friends, spending time. What symptom cluster might that represent?
Negative symptoms?
Exactly. So these are negative symptoms, symptoms of things that he should or could usually do, but is not doing. So it's like amotivation, maybe a little bit of anhedonia, although he's not saying that he's not enjoying it, but he's at least not doing it, and some asociality. Yeah, these are the experiential negative symptoms. We don't know much about the affective flattening and alogia. That would be our 5 A's. And what about the second bullet? What kind of symptoms would that represent?
Cognitive.
Pardon me? Can you say it again? I think I heard cognitive symptoms, but there was like a little bit of an interference. Yeah, so these would be cognitive symptoms. He has hard time, most likely, as we can infer, problems with attention, correct? But he's also not enjoying it. So is it anhedonia, or is it that basically he's not enjoying it because he can't concentrate? Okay, and those would be also questions that you might want to ask. Do you actually want to do it? What keeps you from doing it? Yeah. And what about other ways where you can't concentrate? And we'll talk much more about symptoms and how to answer or how to get answers to them. So let's talk about CIAS. Actually, and that's the answer to question 1. It's about 3/4 of patients have cognitive impairment compared to the general population. It's 3/4, rarely is anything 100%. Now, if you also, when you compare the cognitive function of the patients with schizophrenia against their mother's cognitive ability, it's most likely higher than 80%, because they should have been better than the general population. You're capping everyone when you just compare to the general population. But the answer is about 3/4 or more when compared to the familial cognitive abilities. It significantly impacts daily functioning. There is no bedside testing, and we'll talk about some possible tests, but that's a big problem. That's why we need to ask the right questions, and we'll talk about that. It's difficult to evaluate them. And by the way, patients may not complain about it. Either they don't notice it, or for them, it's the new normal. This is who I am, or they say it's maybe a medication side effect. And we don't ask about these things. So CIAS is important to know about. Schizophrenia has positive symptoms, negative symptoms, cognitive symptoms, but then there's also mood in 30% of patients, and ultimately all of those converge on functional deficits because they are related to functioning, each of them. And obviously when you have functional deficits, that might then fuel also mood symptoms. So another question for you: when actually do cognitive deficits in schizophrenia first appear? Is it A, prior to the first psychotic break? B, around the time of the first psychotic break? C, within 5 years of the first psychotic break? Or it happens really in later life? So before, during, a little after, very long after. Please make your choice now. What's the evolution and the temporal trajectory? And here you see it. It seems that cognition is the first thing that goes. And that's why Kraepelin called it actually dementia precox, because he saw it in young people where you shouldn't see cognitive disability. And when you go back before the first episode and look at school performance and other things, one can see that in early or later adolescence, there is already a cognitive decline. And that may be around the time of pruning. We're all born with lots of synaptic potential. And during adolescence, when we're born also with a lot of excitatory synapses so that we can respond to the world, run away from prey. But then we'll get more inhibitory synapses that build during adolescence so that we can have this excitation inhibition balance. And schizophrenia may have EI imbalance. Too much excitation in some areas, too much inhibition in others. And there's pruning to make the brain more efficient, so things that are not connected are pruned down, and there seems to be over pruning in people with schizophrenia, and that gives you neural network dysfunction. So cognition is the first representation of that, and then negative symptoms come second, usually during the clinical prodrome, and then the true first psychotic episode, the positive symptoms, they happen actually last. Next question. Which of the following reflect deficits in social cognition? Now, this is something that has only been recognized a little bit later than all of the negative symptoms that even the German psychiatrists described 150 years ago. So is social cognition difficulty in identifying emotions, difficulty in feeling connected to others, difficulty in inferring people's thoughts, difficulties reacting emotionally to others, or all of the above? So what is social cognition? That's actually the highest order functioning that is more and more developed the more you get into the mammal life. And obviously then monkeys, non-human primates, and then humans have this developed a lot. And there is a problem in people with schizophrenia. But in what? In A, B, C, D, or in all of them? So here you see the cognitive deficits of schizophrenia, which converge on lower IQ, about 1 to 1.5 standard deviation below. And it's about processing speed, attention, working memory, verbal and visual learning, reason and problem solving, and social cognition. So processing speed is basically motor tasks doing something quickly. Attention is focusing on things as short term. Working memory is keeping something in your memory for a more prolonged time, but it's still something that you then execute. And obviously verbal and visual learning is more long-term acquisition of information. Then the frontal lobe has to do a lot of integration of things, and that's problem solving and reasoning, executive functioning. But social cognition is actually everything we just saw on the other slide. It's recognizing, so getting the input, processing, and then judging your own emotions and emotions and thoughts of others. And when that's defunct in a way, then you have a hard time interacting with others, you're misreading them, and it might actually also fuel psychosis and delusions. So now we'll take the same dimensions and translate them into real world functioning and things that you can ask about. So attention has to do with how long can you actually focus on a book. Oh, I have to put it down after 2 pages. Is that what it usually was? No, this is new. I hate it. I stopped reading. And that's what Joe had. He was an avid reader. He loved it. And now he just couldn't pay attention. He hated it. What about the movie? Can you focus on the plot? No, I walk out because oh, my brother has to tell me how this hangs together. I can't connect the dots because I can't pay attention. Obviously, when you have residual positive symptoms, that can also interfere, but it might be just a symptom in and of itself. Working memory. So you read a number and then you dial it. Can you keep it in your mind? And generally, the phone companies recognized from psychological tests that the average person can keep 7 numbers in their mind very nicely. Now, once you have patients who have schizophrenia, that digit span might only go to 3 or 4, and you might then have to look back at the sheet where the number is listed. And you may know that when you are sleep deprived after a call or so, or you party too much, you can't keep that in your working memory. Or you are asked 3 questions during a talk presentation, and you can only remember the first one. You've answered it, and then you have to ask, well, what were the other questions? That's like working memory. Verbal learning and memory is remembering a list of items and then going to the shop and bringing home 7 and not 5 or 3 items. Visual learning is where do you put things, and that goes also in dementia. So people might think, well, I know I put my keys or my wallet here, it's not there anymore. Somebody may steal from me. That's often then also a reason for some of these delusions. Reason problem solving, can you actually change based on changes in the environment, your approach, speed of processing as the touch screen. And then the social cognition we just talked about. Can you know, can you judge, can you interact with people's feelings, thoughts, and be supple in conversations. Now here you see how much patients are below the norm. So if 50 is the population norm and 10 points is 1 standard deviation, then 40 is 1 standard deviation. You can see almost all these mental operations are at least 1 standard deviation below, but 1.5 to even 2.5 standard deviations in some cases. And that makes it very hard for people to function, even when the positive symptoms are improved. Now, how much do these problems with cognition and other problems interfere with functioning? And you can see here that verbal memory, we are storytelling monkeys. That's what makes us human. And that's what has helped us to develop our frontal lobe. We sit around a fire and we talk, we remember things, and language helps us to then build upon language. And then we have storytelling, and then we have writing, and now we have computers where the knowledge is not just what happens in the moment, and we can build on it. And verbal memory is so important for everything in functioning nowadays. But also vigilance, if you're not paying attention, how can you respond to the world? Executive functioning, and negative and cognitive symptoms hang somewhat together, and social problem solving has a lot to do with negative symptoms. If you're not motivated, if you're not basically attending any functions. And then we have some possible associations also with some reaction time, visual memory, and then psychotic symptoms have a negative association. When you have a lot of psychosis, you can't function well either. But most of our treatments are not doing too poorly for positive symptoms in most patients. What's often residual are negative and cognitive symptoms. So what the functional relevance is really big, especially for real-world functioning. And the cost of schizophrenia, therefore, is both direct and indirect. Direct because people may not remember taking medications, make it not to the bus and the doctor, but indirect is the largest. Unemployment, basically requiring hospitalization cost, care of others, and so forth. And cognitive disability is certainly one of the reasons why people have particular problem with functioning in the work and educational environment. There are lots of cognitive impairments, and patients may not report it. I've already mentioned that might be because they don't have illness insight, because they don't have insight into that their cognition has gone, or they take it as the new normal or misinterpret it as a medication side effect. There's a weak correlation between objective measures and subjective assessment, and basically disorganization may also be part of not being able to judge this. But you can ask about hard facts, not opinion, as we mentioned before. What about reading a book, paying attention to a movie, and being able to recall things when going shopping, or do you have to go 3 times? Now, formal assessment of cognition is really difficult because we mentioned it before, there's no bedside testing, we have limited time, it's basically given mostly to the neuropsychologists, it's a black box what these assessments are. So that's really an issue. And if, or hopefully when we get an assessment, when we get a treatment tool for cognitive disability, we'll also get assessment tools with it, because otherwise it will be hard to judge what patients' level of cognition is. Now, how can we assess cognitive impairment associated with schizophrenia? CIAS, paper pencil test, computerized assessments. And here you see some of them that can be and have been used. But if you look at the far right column, your heart already starts to sink. Because, oh my God, I have 15 or 20, sometimes 30 minutes of a med check visit, or I have psychotherapy of 30 or 45 minutes. How on earth am I fitting in 15, 30, 60, or 90 minutes? So that's obviously not possible. And we need tests that are proxy measures for the remainder of the cognitive abilities. And hopefully those kind of computerized tests on a phone or a proxy test that measures many dimensions like the digit symbol substitution test or so will be much more part of the game once we can actually treat cognitive disability. Here are different tools and batteries. One is free, it's the NIH toolbox. But again, this is not feasible and scalable to our general treatment approach. But www.nihtoolbox.org might be something you may want to look at. www.nihtoolbox.org. Now, what's the difference between cognition and cognitive disability and positive and negative symptoms? Let's return to Joe. You already know that he had a psychotic episode a year ago. He's currently on 4 milligrams of risperidone, and his positive symptoms largely resolve. We know that. We also know he has little interest in going out, meeting prior friends, spending time with his brother, and he doesn't read newspaper or books anymore, which he did enjoy before. Now we get new information. He uses marijuana intermittently to chill, but does not have comorbid substance use disorder. It's just really intermittent and mild. However, he has gained 20 pounds and feels in a brain fog most of the day, and he really does not like that. Upon examination, you detect reduced arm swing when walking and some elbow and neck stiffness. All right, not uncommon. You see that every day. So what's your differential diagnosis for this patient now in his current state? Are these primary negative symptoms, secondary negative symptoms, primary cognitive symptoms, secondary cognitive symptoms, or comorbid depression? So what do you think are we seeing? Primary or secondary negative, primary or secondary cognitive, or depressive symptoms that impair the patient's functioning right now? Okay, so here are data put together into a graphic that tells you what can give rise to secondary negative and cognitive symptoms. The good thing is we can do something about them. So in blue, you see psychiatric conditions, in yellow, side effects of medications, in green, physical problems, and in gray, environmental problems. So when somebody has depression, the patient doesn't talk about being depressed. You can have pseudo dementia. So somebody is so slowed down in their mentation that they have secondary cognitive symptoms they can't think, or even secondary negative symptoms that they don't have the drive or the power or the energy to mix with other people. Also, people with social anxiety disorders might refrain from social interactions, those with full substance misuse, or positive symptoms. If people are afraid of others, they may not mix with them. Now, he doesn't have any of those. That's out. But reduced arm swing, elbow and neck stiffness, risperidone 4 milligrams, well, this could be EPS. And the basal ganglia that in the strip, the neuromotor strip, are responsible for integrating motor symptoms. And when you slow them down, we have a problem with EPS. The basal ganglia are also a relay station between the frontal lobe and the cerebellum and can also slow down mentation. So EPS is not what you want. And then he said he gained 20 pounds and is in a brain fog. So he might be sedated from the antipsychotic. And when you have weight gain, you can also decrease cognition via inflammation or in the long run, in obesity or diabetes, also vascular problems in the brain. So we need to ask him whether he's snoring, whether he has interrupted breathing. Does he need treatment for sleep apnea? We don't hear anything about chronic pain. And then obviously stigma can keep people from reaching out to other people or being active psychosocially, or environmental deprivation can do the same. Here is our meta-analysis looking at metabolic syndrome and its constituent components and cognition. So everyone in these studies that we meta-analyzed had schizophrenia, and some had cardiovascular risk factors and some didn't. And you can see those with metabolic syndrome, diabetes, and hypertension had significantly lower cognitive abilities. So we make cognition worse by giving patients medications where there's a lot of weight gain or cardiometabolic problems. The weight gain was in the direction of worse cognition, but in and of itself was not sufficient at that time. And here are data from the CADI trial. Remember, chronic outpatients, 1,460 of them, randomized to 4 atypicals, olanzapine, quetiapine, risperidone, ziprasidone, and 1 typical agent. And at 2 months, there is an increase of cognition between 0.1 and 0.2 standard deviations. And remember, they were up to 2.5 standard deviations below the norm in the composite. So this is not cutting it at all. It may be actually practice. And here we are now maybe at 0.2 to 0.45. This is most likely practice effect and doesn't really normalize patients. Now, these were chronic patients. Is there a difference in first episode patients? These are data from the UFES trial. And you can see between 0.35 and 0.5, again, no difference between first and second generation agents like in the CADI trial. Although we would think that too much dopamine blockade could make cognition worse. So this is maybe just practice effect and not much more. But we're not normalizing the patients, and there might be also some secondary cognitive symptoms that improved because positive symptoms improved. So let's go back to Joe. Risperidone 4, little interest, he has the brain fog, little arm swing. So what would you do? Would you decrease the dose of risperidone from 4 to 3 or 2 or 1? Would you add an anticholinergic? Would you switch to a long-acting injectable? Would you switch to olanzapine? Would you switch to lumateperone, lurasidone, or cariprazine? Or would you add an antidepressant? So what's your choice of treatment in this person where we said they may have quite a bit, or at least a little bit, of secondary negative and secondary cognitive symptoms? What's the best strategy? Anybody who wants to voice their opinion in addition to voting?
I think one thing I might try first is just schedule frequent follow-ups and reduce the risperidone.
Okay, so reducing the dose of risperidone would be one, but you are saying you would increase the number of visits, a frequency. Why?
Because if I'm reducing his antipsychotic, I want to make sure he doesn't have a significant relapse and other symptoms. And I feel like that's the most responsible thing to do if I'm going to reduce the dose when he's otherwise stable and positive symptoms.
Great choice. Yes. Okay. Anyone? Anything else? Would anybody add an anticholinergic? And if not, why not? Or switch to olanzapine, or add a long-acting injectable, or switch to Luma, lurazidone, or cariprazine. Add an antidepressant. Anyone who would or would not do it, and why?
I'd have hesitance in adding an anticholinergic because it might cause cognitive impairment. It might help the EPS, but I feel like you're just trading one problem for another. The long acting, it might get more steady state, but you also might commit him to problems that you already are seeing. So I think I'd wait on that, though. That's still reasonable to consider. I've anecdotally heard reports that olanzapine actually can have some more preservation of cognition. I don't know if that's true, but I think that that would be an option. You're still going to have all the metabolic problems and maybe worse. So
I
Yeah.
also feel that switching to olanzapine or adding an anticholinergic would just worsen the sedation, since that seems to be a little bit of a problem for him already.
Yep, the olanzapine could worsen the sedation, the brain fog, and also make maybe weight gain and metabolic syndrome related cognition worse. That's a possibility. So the first person, the data on olanzapine improving cognition independent of improving positive symptoms are not that great because it's also anticholinergic and antihistaminergic. The anticholinergic addition is one problematic. You could make cognition worse, but B, also with EPS and an anticholinergic, the risk of tardive dyskinesia goes up. So we want to be below the threshold of EPS and not mask the EPS. So what about an antidepressant or a switch to lumateperone, lurazidone, cariprazine?
We can switch to lumateperone or lurazidone or cariprazine just because their data shows less metabolic side effects. Lumateperone in the animal studies is a partial agonist on the presynaptic receptor, so that could possibly preserve some of the normal function of the dopaminergic networks. But in the real world, I think the options that most people would do in practice is actually C, because he's saying he doesn't like the brain fog and he might stop the medicine because of it, and people just focus on preventing positive symptoms or psychotic episodes.
And what about the antidepressant?
The antidepressant depends really which antidepressant, but it could lead to more weight gain and metabolic side effects. But at the end of the day, we're not treating really the thing that we want to address in this patient with an antidepressant.
Okay, great. Thanks for all the very pertinent points. So just adding something to this. So we already talked about the anticholinergic not being a good idea. The long-acting injectable, he is taking the medications, otherwise he wouldn't have the side effects. And it wouldn't really decrease most likely so much the weight and the brain fog and everything. So it's most likely not cutting it. We talked about olanzapine. Antidepressant treatment has shown to improve negative symptoms, about a 0.3, 0.35 effect size. If you don't use mirtazapine, but rather fluoxetine, escitalopram, sertraline, then you wouldn't have the weight gain, but it wouldn't treat the cognitive symptoms. It would potentially help with negative symptoms, and he's not depressed, so it wouldn't treat the pseudo dementia. Decreasing the dose of risperidone has obviously a risk. Yeah, you might undercut it, but he may have had an overshooting dosing in the inpatient unit. He's a first episode patient, maybe 4 hours too much, we see that because of the EPS. So going down to 3 and seeing whether without EPS he has less of the cognitive symptoms is reasonable, but you may also risk potential relapse. But since he's super threshold for EPS, going down, I think, is a first very good strategy. But if that's not good enough, and you wouldn't cut the sedation most likely enough, you wouldn't cut the weight gain, then a switch to a less sedating, less weight gain producing drug might be helpful. And here there are 3 of them that share this. Cariprazine has data for negative symptom improvement, and that's better than risperidone, but it's a partial agonist, and he failed aripiprazole. Now we don't know, did they wait long enough? Did they go high enough? So be it as it may, any of those 3 would be good. You'll see that we did something else here, but I think those would be the 2 best strategies. Now, is one antipsychotic better than the other for cognition per se? This is a head-to-head meta-analysis. The answer is no. The only differences in black are related to Sertindol, which is not even available in the US. So in general, at least in people who are on an antipsychotic, there are most likely very little differences. This is strategies of adding agents to the antipsychotic, and we did find in our meta-analysis that antidepressants were better than placebo for cognition, but the effect size was minuscule, 0.10, so that's not recommendable. And in this is an umbrella review that we published in the Journal Psychiatry. Basically, even though NMDA antagonists looked that they did something, this doesn't make any sense biologically because we want NMDA agonists. We want glutamate to increase. And a lot of these studies were small from China, not really qualitatively high. So we couldn't recommend any augmentation treatment at the moment as effective treatment for cognition by adding it on. So in this case, the patient was switched, in this case to lumateperone, potentially the less weight gain, sedation, and maybe this partial agonist effect can also help. Positive symptoms remain stable. That's another question. Do I want to rock the boat? Am I at risk that he only responded to risperidone and he won't respond to something else? Well, he's a responder to dopamine antagonist, and he's a first episode patient. So it's, I think, reasonable to assume that he will respond to another first-line agent. We don't know what happened with the aripiprazole. Was that the partial agonism? His neck and elbow stiffness resolved. He doesn't, because lumateperone is 40% postsynaptic dopamine blockade at the 42 milligrams. So that's like clozapine, that wouldn't cause EPS or akathisia. He lost 10 pounds, and he's not sedated anymore. He has re-engaged with his younger brother, watching movies and going for a walk with a dog. But we've resolved some of the secondary negative and cognitive symptoms. There are lingering issues. He can't watch a full movie. He can't concentrate on the plot that long. He still refrains from reading, finding it just too difficult. He resists discussions about trying to go back to college and pick another education or training. He compares himself to his usual self before, and he feels he's a loser. And both he and his family are increasingly unhappy with him and himself in this situation. So what would you do now? You've done what you can with your pharmacology. It worked partially, but not fully. What's your next step with Joe? Would you start social skills training? Recommend aerobic exercise? Add cognitive behavioral therapy? Start a social cognitive training group? Start cognitive remediation therapy? Add an antidepressant? Or counsel Joe and his family, sorry, that's it. It ain't get better than that. So what would you consider as a next step, and how much of that do you have available? How much is the patient willing and motivated and able to do? All of this we'll discuss, but is there evidence for any of this A through G that you may want to consider? Please make your choice now. And then we'll go through the elements. So the antidepressant we've already heard about, that's 0.1. 0.2 is a small effect size, 0.5 is medium, 0.8 is large. So that doesn't cut it. If he had been depressed, then an antidepressant is very reasonable. That can give secondary cognitive and negative symptoms. He doesn't have it. But then we want to activate him. And we can do that either cognitively or behaviorally or via sports. So let's look at the current recommendations. Actually, cognitive remediation does work. People can learn, and the effect size is small-ish, 0.3, not bad for cognition. For functioning, it's even smaller, 0.2. And interestingly, those that benefited the most were those that started at the lowest level. So fewer years of education, lower IQ, and higher baseline severity. And also, not just leaving people to their own devices, trained therapists, structured cognitive strategies, and embedding it in psychosocial rehabilitation. Now, that's asked a lot, correct? You need to have it available, and you need to also have the patient want to do it and continue doing it. You could use computerized cognitive drill and practice. This doesn't have the same effect across all cognitive domains, but still improves some: attention, working memory, positive and depressive symptoms, but again, in a smallish 0.3 effect size. And there are several cognitive domains that do not improve. And actually, social cognition and functioning did not improve by just drilling. So if you have cognitive remediation and you have a therapist or psychosocial intervention, you may also affect cognition as well as functioning. And then you can do exercise, but it has to be aerobic. So just strength and calisthenics, doesn't work. So exercise works for cognition, again, with this magic 0.3 effect size, working memory, but social cognition, because we do sports a lot with others, that improved actually almost with a large effect size, 0.7, and attention. So people are more alert because they have more oxygen in their body and brain. But it didn't work for everything. And it was also better when you have interventions that are supervised. And how many of us have actually a supervisory activity program? And then when you have negative and cognitive symptoms, how motivated are we to exercise? How motivated are people who have these symptoms in addition? But based on these meta-analyses, the EPA, the European Psychiatric Association, makes certain recommendations. Use second-generation agents. Don't block dopamine too much. If you're on a first-generation agent, switch. No clear superiority of one atypical over another. We've already discussed that. In terms of non-pharmacologic recommendations, cognitive remediation. There are some that are non-gamified, based available online, but people start and stop very quickly. Social cognitive training, okay, and we want them to be delivered by trained therapists and part of an integrated social rehabilitation program. So that would be like in a day hospital or rehab unit. But you in an outpatient office have a hard time really offering this in an effective way. Physical exercise, of course, recommended, ideally in a group setting so that people can motivate each other. And lifestyle interventions, we mentioned you don't want people to be obese, have diabetes, or hypertension. So anything they can do to activate themselves and have better lifestyle actually would improve cognition secondarily. Now, we don't have anything approved for cognition currently in terms of pharmacology, but I'm showing this slide because just to show that it's not for lack of trying. So many things have been tried, and one of the questions was obviously which mechanism is currently being tested a lot, and we'll get to that. So there was a glycine transporter 1 inhibitor that enhances NMDA glutamatergic functioning that didn't work for negative symptoms. That was unfortunate. We have glycine transporters that are relevant because we know that glutamate can help cognition, and the glutamate NMDA receptor has both the allosteric, the orthosteric site for glutamate, but then an allosteric site to the side that either enhances the signaling and the binding or brings it down. And glycine, D-cycloserine, D-serine are these coagonists, basically. So we're trying to enhance the coagonist activity to then enhance cognition. And this didn't work either. The serine didn't work here. These all of these, although pharmacodynamically it makes sense, it didn't work. GABA was one of the answers. We don't want to agonize GABA. GABA is a benzodiazepine receptor. When you do that, you're actually sedating people. Now, one of the answers was M4 agonist. The M4 receptor has nothing to do with cognition. It's the M1 receptor. And one treatment that hopefully we'll have in our hands in a year's time for psychosis is xanomeline impaired with trospium. That's an M1, M4 receptor agonist. But the M4 alone is not pro-cognitive. And basically, that's not yet, even xanomeline is not in formal testing for cognition per se, although they're cognitive data. I don't expect you to see any of those lines in separation, but what I want to point out is that in a huge meta-analysis of many, many, many agents, the only one that, when you pool everything together, has some signal is the pro-glutamatergic, and that would be, that's the right answer, the glycine transporter inhibitor. That's being tested right now as in the phase 3 study because phase 2 was positive. I'll show you the data in a minute. So we want to enhance glutamatergic drive. The cholinergic wasn't significant, but we haven't seen an M1 agonist yet, and xanomeline trospium will have to be studied for it. And then we had 5-HT inverse agonism, that would be pimavanserin, no data for cognition. GABA, I said, we don't want an agonist. That's a benzo kind of approach. So glycine transporter 1 inhibitors are tested. In these 93 studies and 5,600 patients, when you put everything together, you might bring it over the finish line, but it's a 0.1 effect size. And we need individual medications. And when you look at individual domains, nothing really works, despite of the high number of studies. So what's currently studied, and that's the right answer, is iclepertin and the glycine transporter inhibitor, making glycine more available because it's not taken out of the synaptic cleft, thereby enhancing NMDA glutamatergic functioning. That's phase 3. Luvadaxistat is in phase 2, so it's another approach where you're not inhibiting the uptake of glycine, but you're basically inhibiting the enzyme that breaks it down. So it's not, it's basically switching off the drain. But that's basically not in phase 3 yet, and we'll see what happens. And we have 2 phase 1 studies that look at different partial D1 or another guanylate cyclase stimulator. But what's really in development right now, and we'll know in a year or in 6 months whether that works, is the glycine transporter inhibitor. And that's based on this phase 2 study, where iclepertin, a glycine transporter 1 inhibitor, was given at different doses, 2, 5, 10, and 25. And whenever you see a dose response curve, it makes you more confident that something is happening. So basically, looking at an improvement, basically the 10 and 25 milligrams had the biggest effect. That's over here. Whereas the 2 and 5 were close to placebo. Placebo is down here, okay? But what's fascinating, in my view, in this 12-week study, is what were moderators or mediators of the effect. Moderators are baseline factors, tells you who is going to improve more, whereas mediators are things that happen during the trial, which tells you why something is happening. So basically, 2 antipsychotics that block dopamine too much may attenuate that signal. More negative symptoms actually helped because negative and cognitive symptoms are together, and more cognitive impairment also gave more room for improvement. Interestingly, although benzos couldn't have been given within 8 hours of the assessment, something in the GABA system, when you have benzos overall in the brain, seem to attenuate the signal. So benzos are not good for cognition. And it's younger people early in the illness course, where maybe the brain has not yet lost so much of its plasticity and also gray matter that we know is associated with psychosis. And in this case, females also responded better. So we'll see what the phase 3 study gives you. The problem that the regulatory system puts between a drug maker and the study and us using the medication is that cognition alone, improving something with a p less than 0.05, doesn't assure you, me, the patient, their family, or the regulatory bodies, the FDA, that this has functional importance. So when positive symptoms improve, that's a given. Patients will be better. Even when negative symptoms are better than placebo, the regulatory bodies give you the indication for negative symptoms. But what is a composite score on a battery that takes 60 to 90 minutes, or a domain score on social cognition? The p-value doesn't tell us that it's clinically relevant. So what is needed is a co-primary outcome, and that's functioning. So what's been used so far in these studies is either the UPSA or the scores. The scores is called the basically schizophrenia cognitive rating scale, but it's very dependent on an interview, whether the patient recognizes that they have a problem and improve, what they would have done or have done in the past. It's very imprecise. So in this study, although cognition improved significantly on the MCCB, functioning did not. So that wouldn't suffice to get an indication. So the CONNEX trials need to show both cognitive improvement and functional improvement. Now, since this is an imperfect assessment of functioning, and I think the best assessment would be ecologic momentary assessment, where you actually have someone wear digital tools and then you know how much they walk, how much they're close to other cell phones, how quickly they type, how many messages they get or receive and send out. But short of that, there is the VRFCAT, Virtual Reality Functioning Cognitive Test. And that is people wear goggles and then they have a task. They have to go virtually to go shopping. They have to get the right money with them, have a shopping list they need to remember, go and find the bus at the right time, and then come back with the right items. And it's also not perfect, but it's more like a performance-based measure than a memory or intention-based measure. And it also is very good at not being so sensitive to practice effect, because you can modify the number and type of items they need to get, the bus schedule, the money they need to bring back, and so forth. So the FDA at least allowed any of the two, either the scores or the VRFCAT. This one shows that it's not just a symptom, cognitive symptom improvement, but also functional improvement to then go into the approval. Now, the good thing is eclipurtin didn't have many side effects. So you see here it's very small in terms of drug-related adverse events. I mean, it's like 15 to 20% that even have them. And then very few have more severe side effects. So it would be, as an add-on treatment, well tolerated. So let's go back to Joe. Joe remains on lumateperone, doesn't have relevant positive symptoms. He started accompanying his brother, now jogging with the dog 1 to 2 times a week. So we were able to link his activities with the brother to maybe do some jogging. He tried cognitive remediation, but actually he found it either too hard or too boring. These are non-gamified kind of things, and it's tough to do this again and again. Upon prodding, now he at least reads a newspaper every morning for 5 to 10 minutes. And basically, he's now more likely to even think about going back to some kind of training, because he feels that he's cognitively a little bit more put together. And then obviously you have to set SMART goals for patients that are specific, measurable, attainable, relevant, and time-bound. SMART goals, so that he doesn't have too much of a negative experience, because patients with schizophrenia have so many negative reinforcing experiences where they're not as good as they were or their prior peer group is. And so you need to find things where they excel, where they have a good experience. So the key practical takeaways, giving us still a good 15 minutes for question and answer. Cognitive impairment is present before the onset of psychosis, before positive symptoms occur. It's very early. It's evident during the prodrome. We didn't cover this, but it can also be a risk factor for conversion to psychosis. The impairment is 1 to 1.5 or even more standard deviations below the norm. It's present in about 3/4 of people, affect virtually every patient, but again, 3/4 is against the norm of the population. impacts almost every aspect of the patient's functioning. There's currently no bedside test, and cognitive dysfunction is not very much correlated with the clinical symptoms, but more with functioning. We have secondary cognitive problems that can occur. We can address sedation, EPS, anticholinergic effects, and we don't want to add an anticholinergic. Treatment of cognitive impairment should be clearly a greater focus if we want to improve real-world functioning, and with that also quality of life and well-being. And the current approaches that are not prescribable in a medication sense are cognitive remediation, exercise, and skills training. But again, it's hard for people who often have also negative symptoms to do all of them by themselves. We need help either by family members, like this brother who's keeping Joe in the game, or in some kind of recovery programs. And there's currently no approved pharmacologic agent, and we obviously would very much welcome this to add it to our pharmacologic armamentarium. So let's do the post-test questions. And I don't know whether we can see the numbers because I don't see the questions here with the system, but what proportion of patients with schizophrenia have cognitive deficits? Is it a quarter, half, 3/4, or everyone? 25, 50, 75, or 100%. And Erica, I don't think we have the technical capabilities to show the results. Otherwise, I think I would have seen the question.
So Dr. Correll, I'm stepping in now. I'm Michaela from the France Foundation. The host is the owner of this link, so we don't have the polls in their Zoom link.
Understood. Okay. But the answer was 75% against the population norm. It might be more when you look at the familial attainment scores. Second question, you know Joe, and when he comes through your door, first visit, what will he probability-wise have most likely? Is it positive, negative, cognitive, or depressive symptoms? So please make your choice now. And obviously, all of them are possible. He was on risperidone, he's treated, so less likely to have residual or full positive symptoms. He wasn't depressed throughout, although you know that depression actually can happen in the first 5 years, and suicide, especially early on when people realize they have the illness. And those that have good cognition and depression have poor quality of life and are at a higher risk of suicide. He didn't have that. Negative symptoms, 50 to 60% have it. And when you treat people with antipsychotics, maybe 30 to 40% after the first episode have residual symptoms. He didn't have them. So since cognition is so pervasive, you would have seen most likely cognitive problems, even though you didn't ask for them, because just based on the prevalence, it's the most likely. And then final question repeated here: what agent or mechanism of action is currently under development for cognitive dysfunction in schizophrenia, far advanced in phase 3? Is it GABA agonism, GLIT1 inhibition, glycine transporter 1 inhibition, M4 muscarinic agonism, serotonin 2A inverse agonism, or TAAR1 agonism, trace amine related receptors? Make your choice now. And I hope nobody put GABA agonism, because again, that would be like a benzo. GLIT1 is the answer, glycine transporter 1, because that's where we are most advanced currently with eclapertin, where there was a positive phase 2 study. M4 may help psychosis. That's xanomeline trospium or emraclidine are currently tested for this. Emraclidine is a M4 positive allosteric modulator, but M1 can help. That's part of xanomeline, but it's not currently tested specifically for cognition. Serotonin 2A inverse agonism is pimavanserin, approved in the United States for Parkinson's psychosis, but doesn't really have data for cognition. And TAAR1 agonism, that's ulotaront, an agent in phase 3 development for schizophrenia, doesn't have any cognitive data. All right, so please complete your post-test evaluation using this link. And we again thank Boehringer Ingelheim for their educational grant, but I also want to thank a lot, and you've heard them out of the off, the France Foundation staff members that have really helped enormously putting all of this together. also with the formatting and supporting us during each of those Grand Rounds programs. And I just hope that this was educational and helpful and also somewhat fun. Thank you for having participated in the discussion so nicely already. And I look forward to more questions and discussions now. So you can either speak
Dr.
up
Correll.
or...
Sorry, Dr.
Yes?
Correll, just before we jump into questions, for all of you that are looking at the evaluation link, I invite you to use the one in the chat instead because your institution will be providing CME credit. So I prefer you use that one. Thank you.
Thank you for that comment. So please open the chat. There you will find the link for the evaluation, but also you can type your questions. I will be able to read them, or you just unmute yourself and ask a question directly to me. Any comments, questions, written or oral?
So I have a question. There's a Dr. Cummings that's out in California that talks about sometimes putting patients with schizophrenia on either modafinil or Ritalin to help their cognition and just very carefully monitoring their positive symptoms. Do you have any thoughts on whether or not there's benefit to that, or is it just too risky?
Yeah, I mean, if you or I took a stimulant, even though we may be already pretty much at our good performance level, if we have slept enough, we would still see some improvement of cognition. So it's very reasonable to believe that a stimulant might also help to a degree people with schizophrenia, although often patients before schizophrenia happens are misdiagnosed as ADHD, not that often, sometimes they are, and they don't respond much to stimulants. So it's a little still a question, is the hardware responsive enough to a stimulant? But even if it were, the risk is enormous, really enormous. I mean, you don't know how much the patient takes the antipsychotic every time. They might take a holiday over the weekend. They might overdose on the stimulant to get a little bit high. And even when they're on a long-acting injectable, that would be the only condition where I might try it. I wouldn't do it. It's just a relapse really alters the trajectory of the illness. And you can tell people and their family members, oh, these are the prodromal symptoms. Stop it and come right to me when you have this. We don't catch them when they have the prodrome and the emerging positive symptoms. Patients don't have the insight. They then basically come far too late. Now, modafinil can improve alertness. That's true. It doesn't have the direct dopamine stimulatory effect. So could you potentially try that? There are less data that this might exacerbate psychosis, possibly. But the data are not strong unless you have really sedation. I would rather go from a sedating and antihistaminergic or anticholinergic antipsychotic to one that has less such properties. That would be basically going from the penes to the pips or the loos. So basically ABC, aripiprazole, brexpiprazole, cariprazine, these partial agonists, or going to also lumateperone or lurazidone. Those might be agents to potentially improve cognition via this indirect effect. Be below the neuroleptic threshold, don't use an anticholinergic, and do behavioral activation. But a stimulant, I wouldn't dare. So thank you very much. Then now we have Saber Slim.
Thank you, Dr. Correll. I think we all enjoyed this presentation, very informative. I had a question along the same lines as Nick. Schizophrenia has mood symptoms, and a lot of the patients that I see that I think are schizophrenic get labeled with schizoaffective. And most of the time, those people come to me, like right now I'm at the VA clinic, and all of them come to me on a mood stabilizer as well, mostly an anti-epileptic or lithium, which in my opinion would worsen their cognitive symptoms, make them more slowed. What's your opinion about that? And I also have another question, if that's okay, about nicotine and the nicotinic receptors, and if that has been trialed, or what's your opinion about adding nicotine? Thank you.
Yeah, excellent question. So there is a big mislabeling of people as schizoaffective, although they have schizophrenia. I think we have to be a little bit by the book here. People with schizophrenia clearly can get depressed. You and I can get depressed. They have more reasons for it. And also some brain circuit reasons for it. They can maybe get a little bit activated, hypomanic. That unless it's 50% of their illness, you don't call it schizoaffective. And the depression you can treat with an antidepressant or with lurazidone or lumateperone or quetiapine, agents that are approved for bipolar depression. Really, lithium or lamotrigine. Lithium and valproic acid are really to prevent mania. And really, I would reevaluate the history. How much have you really been manic? And was that really mania? Was it psychosis with disorganization? So you're entirely right. Lithium can impair cognition, and all the anti-epileptics, maybe except for lamotrigine, can also, because in a way they dampen the brain. They increase the seizure threshold. So very carefully, if they have cognitive inhibition, I would slowly go down unless there's a clear person who has had a lot of mania episodes, even if it was hypomania. I mean, that's not a big issue. Patients might have some improved functioning. So you could, even in the beginning, try to go a little bit lower on the anti-epileptic or lithium and see whether that improves the cognition, because they might have too high levels. So that was question number one. And then you had asked about
nicotine.
Yes, nicotine. So we do know that the nicotinic receptors, I mean, the cholinergic system goes into the muscarinic system that we talked about, M1 through M5, but there's also the nicotinic system. And what's interesting is smokers get it right. The nicotinic system is so sensitive to tachyphylaxis. So if you give like a nicotine patch, the brain basically adjusts to it and there is no improvement anymore. What you need is pulsatile nicotinic treatment. That's what smoking does. But obviously you don't want people to smoke, and it's very hard to give this pulsatile treatment. There have been trials with a $1 billion failure, and Seneclin. And Seneclin was an alpha-7 nicotinic agonist that in phase 2 was positive for cognition about 10 years ago. But then unfortunately, phase 3 didn't show it anymore. So we know that the cholinergic system has to do with cognition, because in Alzheimer's, you have a demise in cholinergic functioning. In smokers, you have a brief improvement in cognition. That's why people do it after meal and everything to light up again. Or people who had also EPS related cognitive problems, people with schizophrenia have most likely a cholinergic imbalance. But we also know that the M1 receptor muscarinic agonism can help cognition by increasing acetylcholine in the frontal lobe and some secondary downstream effects on dopamine. So at the moment, we don't have anything to really modify the nicotinic receptor system in sufficient ways to treat cognitive disability. That's a problem. So a nicotine patch would not help. Anything that has a blood level that is too sustained.
Thank you very much. Thank you for sharing your knowledge with us.
Thank you. Dr.
Correll, this is Dr. Summers. I'm one of the chief residents as well. There's a couple of questions in the Q&A at the bottom of the screen.
Okay, it's a different, yeah, I see that now. Thank you for pointing me to this. I was only looking at the chat. Okay, so do you have any advice for discussing prognosis with patients who have been high achievers academically prior to schizophrenia? I have a patient whom I believe has schizophrenia, is currently pursuing a degree in engineering. I've had a hard time setting realistic expectations for his and his family. Yeah, this is really tough, really tough. I mean, not everyone has strongly impaired cognition, but most people have. And then there's also the negative symptom component. I mean, if he wants to continue and can, I would first try to reduce the stress and go a little lighter, because if it's just too difficult, then people might not want to do anything anymore. and maybe justify this by less stress gives you also less likelihood of having another relapse, which can change brain functioning long term. And so take a little bit wind out of the sail, less pressure, and then adapt the expectations to performance. I mean, if the patient challenges himself and can do a certain thing but not others, then basically downtone it. And you don't want to take hope away, and say, this is it, you can now only clean out the garbage. I would say we don't, and that's true, we don't know for you specifically what the effect on performance will be, on your cognitive capacity and your ability to execute it. That's performance, which also has to do with negative symptoms. So let's see, and not stress you too much. Go back more lightly, and then if you see you can do the coursework, we can increase it. If you see it's too hard, we decrease it, or you have to reorganize and reorient yourself. But it's wonderful that you want to do something and that you have high hopes and that the family has it. But too much pressure is also not good. So that's how I would maybe try to frame it. Can you comment on the issues of cognition in aging schizophrenia patients? How about cholinesterase inhibitors? So there have been several meta-analyses. That's why, I mean, in the one slide I didn't highlight is cholinesterase inhibitors don't seem to work for the hardware problem in schizophrenia. So the meta-analyses were negative. But if someone has basically both cognitive impairment that is static with schizophrenia, but then they have beginning MCI or dementia, for that problem, there will be cholinesterase inhibitor effect. Now, if and when xanomeline trospium becomes available, that was the M1, M4 agonist with a peripherally restricted anticholinergic trospium, that was initially tested in dementia patients. So it might actually kill two birds with one stone, helping cognition and schizophrenia, and also treating some of those cognitive problems with aging. And then lastly, thank you so much for an insightful presentation. Thank you. Could you share some information regarding the TAAR1 receptor and cognition? We appreciate you. Yeah, so the TAAR1 ulotaront was the big hope until a month ago or 5 weeks ago. TAAR1 receptors are fascinating animals. Yeah, they are not basically on the cell surface. They're intracellular receptors that float around, and trace amines that bind to them are basically precursors of our current neurotransmitters. So they are shortened versions of dopamine, serotonin, or adrenaline. And when they bind to the receptor, then the receptor does two things. It basically goes to the presynaptic dopamine receptor, creates a bond, so it's called heterodimerization, and then stimulates the autoreceptor, the dopamine autoreceptor, decreasing presynaptic dopamine. And then on the postsynaptic side, it actually bonds with the postsynaptic dopamine receptor and pulls it inside the cell and puts it into a low affinity state. Again, decreasing dopamine transmission without touching the dopamine receptor, or no blockade. It also interferes or interacts with glutamate, serotonin, and noradrenaline. And with that, there is a hope that it could help negative and maybe even cognitive symptoms. There are no cognitive data for TAAR1, and it all looked great until 5 weeks ago when the Diamond 1 and Diamond 2 studies, the phase 2 study was published in the New England Journal, 17-point improvement with TAAR1 ulotaront and 11 points with placebo, 0.45 effect size for psychosis. Oh, and in the Diamond 1 and Diamond 2, the effects of placebo had risen to 14.5 and 19.3 points. So the drug stayed around 18, 19 points and didn't separate anymore. So we don't know, short answer with cognition, whether there is an effect via glutamate. Hasn't been studied, but in animal models it might help. But at the moment we're not even sure it works for psychosis because of the very strong placebo effect. Now the two companies developing ulotaront have already started programs in GAD, generalized anxiety disorder, and in adjunctive treatment of MDD because of the effect on serotonin, noradrenaline, and glutamate. But for cognition, we only have initial data for the TAAR1, for the M1, M4 agonist, that is xanomeline plus trospium. Now we're basically at the top of the hour. Thank you so much for listening, spending your valuable and important time for this educational initiative. I hope this was helpful, both on what we have and where we steer toward. Hopefully, in 6 months, we know whether eclapertin, as the most advanced drug for psychosis, for cognition in psychosis, will work. But there's also luvadaxistat that is being developed. We have a couple of shots on that goal of cognition. Hopefully, one will actually yield enough. And even if xanomeline trospium can be developed further, hopefully within 3 to 5 years, we have something in our hands to not just treat positive symptoms, but also negative and cognitive symptoms. So thank you very much for your attention, and have a good rest of your day.
Thank you
Thank
so
you.
much.